Hello from Treaty 1 territory. My name is Michelle Klimczak, and I'm joining today from Winnipeg. I completed my practicum with Nine Circles Community Health Centre, which is the community-based site of the Manitoba HIV program. This practicum offered a chance to take a broad look at HIV care, focusing on factors driving escalating new HIV cases in Winnipeg. The title of my presentation is a quote from HIV advocate and researcher Carlos Del Rio and summarizes the goal of my project to consider the biomedical advances in HIV care within the context of social justice. It's in this spirit that I acknowledge my privilege and gratitude for this ongoing learning journey on the traditional lands of the Anishinaabe, Dene, Cree, Ojibwe peoples, and the homeland of the Métis Nation. First off, an overview of the most recent Manitoba HIV program report, which informed my project. As many had feared, HIV rates increased significantly in Manitoba since 2018. Per the report, the convergence of houselessness, mental health concerns, substance use, socioeconomic factors, and COVID-19 is driving a syndemic of HIV and other STBBI. My team ultimately landed on looking at what factors support folks in achieving an undetectable viral load through adherence to antiretroviral medications or ARTs. Although this takes a very medical lens, ART adherence has the dual benefit of accomplishing individual health outcomes and population level reduction in transmission per the widely accepted undetectable equals untransmissible or U equals U principle. U equals U implies that HIV transmission is reduced to statistical improbability when viral load is undetectable. I set out to better understand the HIV care cascade here in Winnipeg and seek out promising practices supporting ART adherence. In undertaking the first step of the literature review, the initial parameters felt too rigid to capture the full range of sources I was hoping to consider. So to more fulsomely consider our Winnipeg context, we came up with two additional tasks. The first was an environmental scan of STBBI outreach capacity within the Winnipeg Regional Health Authority, or WRHA, and the second was a chart review of HIV investigations referred to the WRHA in 2021 and 2022, assessing for factors determining whether a connection to HIV care was established. The research question that emerged was, when assessing the population descriptors of those diagnosed with HIV between 2020 and 2022, what supportive interventions have the greatest impact in supporting ART adherence with the goal of viral suppression? And what are the considerations for implementation given the current resources within the HIV care cascade in Winnipeg, Manitoba? This combination approach proved instrumental in refining inclusion and exclusion criteria, and then drawing conclusions from the literature. The chart review and environmental scan revealed gaps and capacity within the system, as well as opportunities to scale up HIV care. The overall methodology for the literature review followed the guidance in Purcell and McRae for carrying out a systematic review within the healthcare literature. The analysis took the form of a narrative synthesis very specific to the Winnipeg context, as informed by the project tasks. Summarizing the literature review process, 3 databases were assessed for articles in 2018 or later, and ultimately 84 sources were identified that fell into 4 categories relevant to the Winnipeg context: differentiated care models, electronic tools, peer-led interventions, and financial incentives. Through the environmental scan and the chart review, 3 notable gaps emerged here in the Winnipeg HIV care cascade. These were processes for engagement and consultation with key populations, data collection infrastructure, and a guiding conceptual model or framework. I'll share that I went into this with a real sense of urgency to identify a list of specific interventions we could consider here in Winnipeg to support ART adherence. The common finding across the literature, however, was that the effect of most behavioral interventions was modest at best and decreased once the intervention was withdrawn. Interventions that don't consider the environments in which people living with HIV find themselves and addressing disparities have limited impact. Our primary task within the WHA will be to articulate and define roles within the HIV care cascade that address inequity. A number of specific interventions do hold promise, however, and I'd like to highlight a few. With the intent from my findings will be to support community consultation processes. In thinking about differentiated care models, the big takeaway here is that eligibility for care outside clinical settings tends to prioritize those who are quite stable health-wise, when in fact, those facing the greatest barriers to good outcomes most often benefit from creative outreach approaches. Additionally, point of care viral load testing and outreach-based rapid start ART regimens offer some novel options for the Winnipeg context. With peer-led approaches, both peer-led approaches and interventions are underutilized in Manitoba, and I'll mention adherence clubs specifically as an evidence-informed example. In this model, one individual picks up meds to distribute to a group offsite from clinical settings. This offers promise locally, as well as a great option to quickly scale up human resources in the midst of a healthcare worker shortage. The electronic models, I think we might have been the most optimistic about interventions that offer remote or virtual care because of perceived efficiencies and convenience. And while the electronic tools seem to be overall very acceptable to people living with HIV, options for real time, two-way communication were most successful, which has implications for efficiencies. I'll note too that some of the tools in development whereby real time medication adherence can be monitored electronically raise some complex ethical questions. Financial incentives are often referred to as contingency management, provide monetary compensation for the achievement of some predetermined health goal. At the outset, this type of intervention may seem highly attractive, but I do want to point to the findings of Gagnon et al. Well, where financial incentives seem to get people through the door, the outcomes regarding viral suppression were not better than other strategies and seem to negatively impact client provider relationships and trust, in addition to raising some tricky moral questions about the commodification of the care cascade. These findings give us some pause for thought in Winnipeg for sure. To wrap up, I'll reflect on the primary tension that I wrestled with over the past few months, which was trying to balance some of the rigidities of established research practices against an evolving understanding of what is meant by the evidence. It's frustrating how hard it is to shake the concern that departing from quantitative data analysis will lessen the impact of the findings. Having said that, the opportunity to dig into the how of the studies that I reviewed proved to be invaluable. Looping back to my presentation title, what I hope to have conveyed is that addressing the HIV syndemic in Winnipeg will require approaches that consider ART adherence through a social equity lens. Thank you sincerely for your attention and so much gratitude to the countless folks who've supported this project.